today. My name's Chrissy Jenkins. I am a clinical practice social worker, LISWCP. Currently, I am practicing as a patient advocate at Palmetto Infusion, AccuRx, so working with chronically and acutely ill patients. My background of 25 years encompasses a lot of medical social work, 20 years in hospice and home health, a couple of years in mental health and therapeutic foster care, but the last 5 years working at Palmetto Infusion. Actually, the owners of the company I had known very well when we were working for their hospices. They reached out and said, "What are you doing these days?" As I was contemplating how many more years can I do hospice. I love it, but it's one of those things that needs to be for a season if you want to take good care of yourself as well as your patients. And they said, we're doing a great job taking care of patients, putting IVs in people's, arms, but we're not taking care of the whole person. So what do you think about this new position? My understanding was social workers and infusion centers is a brand new thing. And so I welcome the opportunity to come and work with them. I think the words they said were, it's a blank slate, take it and run. You know what people need outside of the medical part, so let's just kind of work together to provide something great for our patients. There's a desperate need. So I'm going to go through a lot of slides today, but instead of just talking at you the entire time, please feel free to raise your hand, ask questions along the way. We can make this interactive and as fun as it can be. I'm going to present a lot of different things, some of them in more detail and some a little less specific, but you'll have the slides to refer to. Okay. Let's see here. Okay. Who we are and what we do, why healthcare advocacy and infusion care, navigating the complex healthcare system and accessing patient needs, patient advocate referrals, partnerships, collaborations, and initiatives, and patient story. Okay. That's our agenda. Okay. Who we are and what we do. Okay. Palmetto Infusion was founded in 1999, and they are actually based, I think, out of 40 specific clinics now throughout South Carolina, North Carolina, Georgia, Alabama, Florida, and so that's 5 states, yes. And also with home infusion in some of those states. I am the only patient advocate right now, so we have grown tremendously in the 5 years I've been there. I think when we started, we were just in South Carolina. So we are looking to build the advocacy department for sure. We do have pharmacy locations. We're serving over 12,000 patients on service. And I think the number we have there for 7,404 was just recently broken. In July, we crossed the threshold of over 8,000 life-altering infusions and injection therapy throughout our clinics. So that need has continued to grow. The volume of patients, the number of sites of care has increased. That shows you certainly the demand. Okay. Some of you may not know what an infusion center is. I'm going to hit on this really quickly. It's a physical space that people come to. It is a place where we provide injection therapy, IV therapy, and it's under the administration of a medical doctor or a nurse practitioner, along with registered nurses. And these spaces are specifically located in the communities as well as the home infusion options in those counties and communities that are throughout the states that I mentioned. Private rooms. Okay. If you've noticed, there's been a trend in the last several years of infusion centers becoming more of the modality of care as opposed to the hospital setting. And I think that's happened for a lot of different reasons. The first being that hospitals are set up to do a lot of different things, a lot of moving parts. Our infusion centers are set up just to do that infusion therapy alone. So it's a little more specific and more localized for that. We have convenient drive-up parking instead of the huge parking lots that are located in hospital settings. More comfortable home-like settings with Wi-Fi, blankets, snacks, things of that nature to make it not so sterile and hospital, feel. Also, I think the biggest, move towards infusion centers versus the hospital setting is that they are more cost effective. I think I heard 300% markup potentially when you have an infusion in the hospital setting as compared to a freestanding infusion center. So that model has become the lowest cost model, and insurance companies are really mandating that. So we're seeing that trend even away from doctors' offices where it's not conducive maybe to do Prolia, things like that will come to now to our infusion centers. We also offer complimentary insurance benefit investigations, copay assistance, and I'm going to go into that in a little bit greater detail soon. They do that at the hospital setting too, but if you've ever been in the hospital, they're doing a lot of different things, and so getting some of that financial stuff ironed out, it's a little more complex than it is for just infusion centers doing specifically infusion injections. Patient onboarding and continual support. I won't go into all the very specifics of this because there's a lot that has evolved with this. I think our workflow for intake and onboarding has been updated and revamped multiple times because we've had so many new patients, just the volume coming in to be able to do it faster, better, more efficiently, so that there's less time that people are waiting to get therapies. Intake support technicians are the ones that actually receive the referrals from the community, and we have marketing staff that work with physicians and providers that bring those in. There's usually a 2-hour turnover time once those are reviewed. History and physicals moves on to our insurance benefit coordinators that do all of that fun stuff that I don't particularly enjoy, the prior authorizations, appeals, facilitating those letters of medical necessity. And so they are the liaisons with providers to make sure everything's in place to get that plan of treatment or order moving forward. Then we have our pharmacist. They do a wonderful job, doing the utilization review, lab requirements, and washout periods. We have 3 pharmacies. So we're doing that within Palmetto Infusion. And then our clinical support technicians. Those are people that kind of manage the continuing therapy that goes on, after the initiation. Appointments, scheduling, and triage of phone calls that come in. Okay. Procurement and trade relations. We are a buy and bill therapy management model. Basically, we have a wonderful senior vice president, Brian Scott, that manages all of this complicated operations in terms of, strategic sourcing for market shortages, supply chain issues, partnerships and trade relations, procurement. So you see the drug manufacturer contracting, distributor purchasing, centralized receiving and quality checks, clinical delivery preparation, and infusion and billing. Now, getting to the specifics of my job and what I'm passionate about. Advocacy and action, kind of what does that look like? Why do we need advocates, in general in healthcare? And why specifically in infusion care? Well, we know it's needed everywhere. When I was in hospice, I knew that patients desperately needed that. And I momentarily was wondering if it was going to be as much meaning and purpose working with chronically ill patients. But guess what? They're living for a long time with a lot of problems. And so their needs are just as great, if not greater. So I have kept extremely busy. Lots of referrals that come in. What I noticed first off the bat when I started as an advocate with Palmetto Infusion is that if you don't treat the whole person, you're just missing the boat. From the beginning, that first interaction to deal to build rapport with a patient. To me, if I was on the opposite side of the chair, what would I want? If it was me, if it was my mother, my sister, I've always had a very strong belief in that, treating the person first, a holistic approach to healthcare. Focusing on quality of life, not just the medications. All of our patients are vulnerable in some sort of way. And my job is to assess that situation and to see what needs may be the most prevalent. I kind of coined this term a while back called all hearts and hands on deck. It reminds me of my hospice days where we had interdisciplinary teams. That meant there were a lot of different people doing different things. It's not just me. I'm just one of those people among the village of people that are helping address a patient from the second their referrals received all the way beyond that infusion chair. So it requires a lot of multidimensional, multi-system care coordination and delivery. Navigating the complex healthcare system. That just sounds really nice for a really horrible experience that most people, endure on their medical journey. For every horror story that I could, think back on, when patients come to us, I think the average is up to 3 to 5 years of misdiagnosis or ruling out before they actually receive the definitive diagnosis. So a lot of hurry and wait, people feeling like a guinea pig. But worst, and this is kind of insult to injury, is that most of them come to us bitter and jaded, and I can understand why. Most of them have been, accused of being drug-seeking, of being attention-seeking, a lonely housewife, just a person who likes to pretend they have illnesses that they don't. Things like that have been questioned about, you look normal, you look fine, you can't have an illness and be as sick as you're saying you are and as much pain as you are. So they come to us already feeling discredited. So all of our staff have really been championed to kind of meet patients where they are. When they come to us, a lot of times they're not happy campers. They finally figured out what's going wrong, and now they're going to start this treatment, and they're really concerned and anxious about it before you even talk about the money part. So there's a lot of different things that are happening. People have to trust you. They have to have confidence in you that you actually care about what you're doing. So that's really where we start, is the building of rapport, so that people know that you truly do care about their needs. Otherwise, they're not going to share it. They're going to be afraid of the assumptions that you're going to make, or just feel like they've been dismissed so often. You're going to be another cog in the healthcare system that they've been subject to. Identifying, assessing, and addressing are the main components of what I do, kind of in a assessment, an informal assessment. Since this is not Medicare reimbursed, which is kind of a lovely thing, I can do this, in ways that's custom fit to patients' needs and streamline a lot of the paperwork that's required, so I can spend most of my time with the patient instead of equal amounts of time in paperwork. Unmet needs. A long time ago, as a young social worker, we learned that if you can't, be assured that someone's safety or their basic needs are being met, who cares about all the rest of the good stuff you can do? And so I think it's Maslow's hierarchy of needs that says you have to address those things first before you can get on to all the other things that are important in people's development. So unmet needs, unfortunately, we do have people who are homeless or have some very significant needs. So we try to immediately be aware of those and flag those situations and address those. Social barriers to care. Those are obstacles, things that get in the way of people getting the care that they need. I think that's a buzzword that everyone has heard too much about, because there are so many barriers out there that prevent people from arriving to the care that they need. So we're looking at those things. Social drivers of health. This is a new term. It used to be called social determinants of health. And I read, or actually attended a training that said, social determinants of health just sounds so fatalistic. It just sounds like you're stuck with what you got. This isn't going to get any better. It can't change. So social drivers of health seems a little more hopeful and optimistic that we can steer that in a better direction. People just aren't born and stuck in situations of poverty or, lots of different situations that may be not positive for healthy outcomes. Psychosocial concerns. Those are things like anxiety, depression, all of the mental health and well-beings that come along. Imagine what we just as a general population dealing with all the stress in the world have. We all have bouts of these things in our lives. Throw an acute or chronic illness on top of that, you better bet that the anxiety, depression, and all of those things are ramped up. There's lots of evidence showing that those rates are very high in that population, and especially since COVID have continued to increase. A lot of social isolation and loneliness encourages some of that due to their chronic illness. Healthcare literacy. That's another big one that I'm really trying to get more behind. I guess because we do this every day, this is our job, and we don't realize how poorly informed our patients are. A lot of times I'll ask them, what's your diagnosis? Just kind of start from the very beginning to see what they truly understand, because you can make a lot of assumptions. Some people can't tell me what their disease is. And then you ask about a medicine, I don't know. They have no clear idea. They don't know the difference between Medicare and Medicaid. So you have to meet people where they are to figure out what it is that they actually know about their disease, their medication, and their symptoms, and things like that. So that's been something we've really tried to incorporate in the work that I do, is offering a lot of educational opportunities for patients, because that's where you empower patients. The better they know things, the better decisions they can make. So what parts of a person are impacted, by a chronic illness that I might want to address? Well, everything. What isn't? Social, emotional, behavioral, physical, spiritual, financial, cultural. I don't think I've met a patient in the 25 years I've been a social worker that hasn't been affected by one, or in some way, a little bit of every one of these things. And believe me, when you mess with one of these things, it can be very disruptive to someone's life. There are so many countless stories of losses and adjustment issues that have resulted in the way one of these areas has been impacted. And that's where I do the most of my work. Broker of services. That's really kind of what I can consider myself. And I want to tell you a little bit about how these referrals come in. Patients themselves call. They have my little brochure at the front of the clinic, so they may just call me directly. And the best way to get people to call is say free and confidential. No, I'm not going to talk to anyone about your problem. It's private here, and there's no charge to you. There aren't a lot of social workers outside of certain settings like hospitals and things like that. So having sometimes in a clinic setting this, it may be the first time that someone's actually had the service if it wasn't referred directly to them through a particular program. But all levels of our agency, everyone from doctors in the community, patient services and referrals come in. Even some of our drivers that deliver medicine out to the home setting will call me and see something in the home. I worked in home care quite a bit, so you learn a lot about people when you're visiting their homes. And so there are a lot of needs that are addressed through referrals that come from all levels of our organization. Mental and behavioral health and substance abuse, those are the top two, in addition to transportation, probably being number one, that I address more often than not. The mental and behavioral health, as I mentioned, struggle with our chronically ill and acutely ill population has really become a major issue. And it's one that I refer quite often. Virtual counseling referrals, it may be in-person referrals, bereavement or grief counseling. So I do a lot of referring to those communities where our patients live to fit, what's your insurance you have, what's the specialty, if they're dealing with the loss of a child or they're dealing with an issue of adjusting to their new way of life, loss of independence. So I try to make sure we get those referrals to people so they can get that ongoing mental health. I am trained to provide clinical mental health services as a private practitioner, but I do not do that in this role. I try to get people to those providers that can do this on a regular basis. Substance abuse, as you would unfortunately imagine, is on the rise. So a lot of referrals to outpatient services, a variety of whatever might be available in their areas where they live. Housing referrals. Transportation, it's hard to imagine having a good outcome if you can never get there. Transportation is probably the one that I get the most referrals on a daily basis for. And we can talk a little bit more about that in a minute. Insurance decision making and optimization. How can we make them better informed so they don't make decisions that really impact their ability to have access to care? Food insecurity. Food stamps, food pantries, that is on the rise with the increasing cost of groceries. Advanced directives, a lot of healthcare power of attorneys, living wills. 5 wishes is the one that I often present free of charge to all of our patients. So there's a big need for that, and directing them to other programs and services that can do some of that through legal aid for free. Again, education about disease process, lots of groups through pharmaceutical companies, disease foundations that can help provide some of that ongoing education. Disability applications, and that's a doozy. Most all of our patients are in some process of applying for disability or on their 3rd appeal or denial and having to hire attorneys to appeal that and help them through that process. Medicaid, applying for Medicaid as well is another big one. And unfortunately, for some people, that can't be maintained in the home placement. If you can't live safely in the home or don't have the support, where can we help send you so you can get what you need? So in-home assistance, caregiver support, and some grants for that, helping people that are able to remain in the home. Any questions? Any hands on anything so far?
So with the patients being pushed from the hospital to standalone facilities or providers' offices, there's lots of barriers that providers face with getting patients on service, through authorization process, etc. What have you seen the average time to get a patient from referral to treatment?
Yeah, I think across the board, if you look at getting just any type of care right now, including myself navigating some of that with my own family, it has slowed down across the board. Getting into a neurologist, infusion center, assisted livings, all of that, it takes longer than it should, right? If you're a patient, it should be quick. Unfortunately, we do have a good bit of a turnaround. It depends on the insurance, the disorder, and how many times you're going to have to deal with that prior authorization being denied, letters of medical necessity, the peers to peer. Going back and, looking at other things, the way that we may need to do if the patient can't afford it. So we're hiring just tons and tons of people. We've had 2 or 3 recent hirings of 25 to 30 patient services people at a time just to address that, because it's taking longer with every insurance company, really having to fight harder to get what is needed. So it takes longer than it should. I don't have the exact statistic because it depends on the therapy. If it's a newer one, if they're wanting to switch them to a biosimilar, if it's one not covered by their insurance, do we need to look for an alternative? Do we want to try to move it to a home infusion option? And we don't do a whole lot of we don't do biologics in the home, but we do some self-injectables and things like that. But it's a work in progress, and we actually have some new technology to help with that. And I'm going to tell you a little bit about how we're going to try to increase that wait time. Because if you ask patients, one day is too long when you need something yesterday. The initiatives that I've kind of formulated as kind of core goals for my duties as the patient advocate, outreach and cultivating social connections and community of support is the nearest and dearest to my heart. 5 years ago, I came across some patients that were meeting in a church that said, "Can you come and talk about coping and mindfulness and all that?" And I thought, sure. And when I saw that these patients had themselves come together to offer support to each other when there was really nothing in the community out there, I thought, well, really we should try to do something about this. And the thought to actually seeing something happen doesn't usually happen very quickly, unfortunately. But I was able to get one of our owners there, and he showed up and he saw what was going on. He saw these patients that were really trying to lift each other up. Uplift Encouragement was the name of their group. And he said, let's try to help these patients. Let's fund them so they can become a 501c3. Let's help them do a website. And it took off and it grew. That's probably my proudest moment, and I really didn't have much at all to do with that. They were already doing what they needed, supporting each other in the infusion chairs and coming together as groups where there was a need that was not met. So we were able to, champion that cause with some funding and some additional money. The thing I liked about it, it wasn't a woe is me, let's get together and sing Kumbaya and cry about everything that's horrible, because who wants to go to those kind of groups? Surely grief and loss is something that needs to be honored, but we don't camp out there. We talk about what remains. And so they have had wonderful growth throughout Columbia, Greenville, Myrtle Beach, and also Charleston chapters that have opened. And with additional funding, we have been able to have speakers, professional speakers. So, of course, asking people to come, like neurologists, to come speak for free, or dietitians and things like that, as you can imagine, is not easy. I've spent more hours than I'd like to admit trying to find those people that want to donate their time on a Saturday. Funding has allowed us to provide neurologists to come, dietitians, physical therapists, pet therapy, psychologists, any area, even ketamine therapy. We've asked the patients, because they're the ones that know what they need, right? They're the experts on their own care. What do you want to hear about? And so when they have identified these needs, we've been able to tap into those resources in the community and bring those professional services to our group, in addition to the group talk that they do. The coolest part about that, too, is some of the patients have said, I have new meaning and purpose now from these groups, so I want to talk about what I do. And they've stepped up, and they have really been advocates for newly diagnosed patients or their veteran patients, and really want to remember and give back, because they can remember when they were that new patient with being diagnosed with Crohn's. So it's really taken off and grown. Resource health fairs that they've received some grant funding for, caregiver groups in conjunction with the other groups. So lots going on there. Improving access to care. We knew a long time ago that people were driving way too far to come to infusion therapy. I heard one of them, they were saying he can't get to his treatments, Chrissy, because he says it's just too long a drive. Well, no one had looked to see he was driving 2.5 hours one way, thinking, well, that is too far to drive, so he's spending his entire day with us. Sometimes the drive was longer than the infusion time. So we looked at, what could we do? The first thing was, well, let's find transportation. I'm good at that. I've learned how to, figure out what state, local, or, what money's out there to help, with this transportation. So it sounds good in theory. You get the money, You get the service started, but what if you live in Fork, South Carolina, where no Ubers want to drive 30, 45 minutes to get you for no money until they pick you up, and then they're going to leave you stranded because you can't find a ride back to Fork, South Carolina. There's a lot of rural areas in the states that I'm in. So even if you have the program and funding, it doesn't guarantee that it's going to work well. So our initiative was to address these care deserts. Care deserts are these kind of pockets in the rural community where vulnerable populations of patients are not readily able to access health care. Not just infusion care, but all medical care in general. Even mental health, that's even worse most of the time. So we added locations: Sumter, South Carolina, Fayetteville, North Carolina, Greenville, North Carolina, and Hickory, North Carolina, and put those clinics in those communities where those patients had been driving great distances to get to us. So that was a proud moment to see that happen within the past year. Going back to the transportation, it may seem like, well, it hurts the patient. We know certainly they can't show up and get it. It hurts them. We lost a patient sitting in the chair, but think about all the multiple losses that happen when some of those patients are hospitalized and they have to, they cost the healthcare system in other ways when they're not able to maintain their therapy regimen. Transportation challenges prevent 3.5 million people from accessing medical care each year. It is estimated that patients who don't or can't attend their appointments cost the U.S. healthcare system approximately $150 billion each year. That's a huge number, and that was 2022, so I can guarantee it's higher now. And that's why we see people signing up for the Medicare Advantage plans with the woo of free transportation until they learn the real deal of how that works. They may say 24 round trips when people think it's unlimited, and it's really one trip, one way. So you've got, if you're going to infusion center and back, that's 2. And then in South Carolina, they gave all of those free Medicare rides to the large company that provides the Medicaid rides called Motive Care. So you've got Motive Care that was already overwhelmed, couldn't get the Medicaid patients. So let's throw all the Medicare patients on top of them, Medicare Advantage. So that's why our patients are getting calls at 6 o'clock at night for their Ocrevus infusion the next morning saying, sorry, we don't have someone to come get you. It happens a lot. Okay. Technology, because as many people as you have doing, a great job, working really hard for all the right reasons, you can't do things with a volume that's increasing in a healthcare system that's becoming more challenging. So you have to acquire, technology. TaylorMed actually learned about that last year when I was here attending. We were able to secure technology that's going to help us really organize all of the assistance that we provide, copay assistance, free drug. We do internal hardship, the CPAPs, all the charitable, because we've got a lot of people, and I'm going to give you those statistics, receiving funding that way. And I thought, it was a funny story I took back last year at home. I think it was a group of women from a healthcare system that said when they got the text or the email notification that funds came in from Patient Advocate Foundation, $7,500 for MS Medicare patients. It was like a Chinese fire drill. Everyone's running, and I'm riding down the side of the road pulling off too, doing the same thing, calling people. Money came in, go grab it right now before it closes in an hour. This is supposed to help us secure a better system that will be more successful for that. So we'll be implementing that as we speak. So I don't know quite how that's worked out yet. Okay, trying to close this window out here that just popped up. Okay. We also are piloting a program for artificial intelligence that's helping us make those massive amounts of phone calls and that our staff couldn't possibly do efficiently and productively as well as AI could. Don't know a lot about that. I was a little skeptical at first, but it seems like this is something that could potentially help our patients. So we're investing in that pilot study as we speak. CPAP dollars. I was wondering, because I knew I was helping with some of these of what we had recovered, and this is money that comes from copay assistance, from foundations. If you can look in 2019, it was 5.8 million. And it didn't surprise me in 20 and 21, that's COVID, 7.9, 7.8 for the entire year. 2022, $11 million for our patients recovered. 2023, this was just January to June, that's half a year, $8.5 million. I'm curious to see what's happened since June, because a lot of that money has dried up. It kind of came and went because there's more people going to those pots of money. So I don't know how we'll end the year out, but I know the funding has really almost depleted across the board for a lot of our top therapies. The correlation between prescription abandonment, initiation, and medication. I'm seeing lots of statistics of this. It's just sad. It's tragic. There has to be a way of us doing this better. The stories I hear on a daily basis of people that abandon treatment, ration their medication, decide they're going to take their Zoloft every other month instead of every month. So you can look at this, the likelihood of abandoning specialty drugs, increasing sharing over $100 associated with up to 75% abandonment rate for certain specialty drugs. This is 2023, just came out, University of Iowa College of Pharmacy. I see and hear that every day. When you're calling someone and they're on a fixed income or they're disabled and they find out they have an insurance plan that is not going to cover very well for some of the medications that we do, that's what happens. They don't do the therapy. They, find ways to cut expenses that they probably shouldn't, stopping paying their mortgages, taking a second mortgage out. Lots of horror stories that I could go into about how medicine costs impact just every part of a person's life. It's a financial burden. It's toxic. Okay, and on that note of all the sad, depressing, how challenging this work is, I did want to share one patient story. It's a feel-good story. I try to find one every week to remind me why we do what we do and try to lift up some of the practitioners I work with that hear and see some of this. This is one of the reasons we do this. We have a 47-year-old woman of color when I first started about 5 years ago, diagnosed with relapsing, remitting multiple sclerosis. She was ordered Ocrevus. Husband had left her for another woman, so she's divorced with 3 young adult children, so she's not getting any more child support. No income and uninsured. So we had a lot of things to do quickly, looking at the marketplace. She didn't make the minimum amount, $13,000, so she couldn't get marketplace insurance. She was in the process for disability, so we, of course, went to free drug. You have to have MRIs and scans to be able to continue to get therapy. Well, if you don't have insurance, it's hard to pay out of pocket for those, so we had to tap into programs in the community, Tidelands Community Cares, to help pay for the MRIs. We had to get transportation services, tapped into MS Foundation, MS Society for transportation, free visits to the neurologist. We had therapy groups, support groups that she and her family attended. On and on and on of the things that we had to do to help address some of her immediate needs, not being able to pay the electric bill because she was living in a trailer with a $400 a month electric bill, things like that. So problems that we had to address, psychosocial issues and concerns. She was struggling with her coping, no surprise, but she was able to participate in some counseling in the community that we connected her with, in addition to the group support that we provided her children as she was adjusting to her diagnosis. Eventually, of course, after multiple appeals, she was able to get her disability approved. She was able to get onto Medicaid. She was able to become, a patient that was compliant with her, with her therapy, come in for her Ocrevus. And the best part of all that, because we know all those things are great, is I ask every patient, what is most important to you right now? She had a daughter. No one in her family had graduated college. And she said, I want my daughter to go to Clemson University, and I want her to become a veterinarian because that's her dream. And that's exactly what happened. She was able to graduate college. She said, I don't want my burden to be her burden and for her to carry the weight of this. You know, I don't want her to be held back by me. So I got to see the graduation picture. She's going to be a wonderful veterinarian, and that was a win in her book. You know, all of this was wonderful, but that was what was most important to her. So that's why I do what I do. That's why I love what I do. And I try to remember these success stories, because for every success story, there are lots of people still struggling and not getting what they need. That's why we're all here, to learn so that we can do better for our patients. The next slide doesn't look very promising, and I like to be optimistic, but they're projecting now 7% rise due to inflation increases that will be passed on to insurers and pharmaceutical costs. So next year is going to be not only more of the same, but more challenging. There's another recent statistic. So advocacy is now and will be greater in demand, more necessary to help desperate patients struggling, because next year there'll be all of these additional financial concerns that will be impacting not only them, but the providers. All of that trickles down. So we're going to have to get more innovative about how we're going to address these issues, working together. Thank you.